Hello, everybody. Welcome. My name is Amanda Ellison. I'm the Executive Director of the Wolfson Research Institute for Health and Wellbeing here at Durham University. On behalf of our co-directors, our senior officer and myself, I'd like to welcome you all to the first public lecture of this year's Wolfson Research Institute's engagement series. This year, we'll be focusing on bringing you the unique brand of interdisciplinary research that we do into aspects of health and wellbeing that matter to you. This series is a really exciting one, so please save your dates and register as you can by finding out what's coming up over the next few months on our website. We're going to record this lecture as a resource for the future, so if you have a problem with that, pop something into the chat for Susie, our senior officer, and our technical wizard to do something with. What better way to start our series with a new approach to an old problem, that of pain. So as we are soon to find out, pain is much more than a medical problem that can be solved by a pill. It's influenced by how we live, what we eat, our happiness, all sorts of things. It's a biopsychological issue, and it's a social issue too. And we'll never be able to help people with chronic pain without a clear understanding of that. And that understanding needs to flow from the patient through academia to the medical practitioner spectrum. So here to tell you more about the Wolfson Research Institute's own Pain Academy and how it addresses this issue is its leader, Dr. Paul Chazot, and general practitioner, Dr. Francis Cole, who has been working together to effect real change in an opioid prescribing hotspot. So without further ado, I'll pass you over into their capable hands. Paul, Francis, welcome.
Thank you very much, Amanda, and welcome everybody to this lecture where we're going to share with you, as Amanda's highlighted, some key aspects about directions of travel for now and the future of persistent pain. In essence, we're all working together to enable people to live much better quality lives, healthier lives with their pain. So we're trying to enable them to move from a suffering to a living well. And in the next slide, I'll show you a little bit more about the problem that they're struggling with. Is the size of the problem is enormous, particularly in an aging population. And the figures that we're dealing with are millions of adults. When we're dealing with, certainly with persistent or chronic pain, we're dealing with the way it affects people from a mild to a moderate to a severe level of disability. And you can see from the figures that can run up to 15%. It's a particular problem in older people, particularly over the age of 75, and is part of, no doubt, part of our aging population issues. Now, when we're talking about pain, we're not totally focused on the biomedical approach. It has its place in the early days of the emergence of pain. But as time goes on, we need to get our brains, our minds, our communities, our society around the fact that actually what is changeable is the what before we start launching in with the how. So what's crucial to make sure everybody understands is that when persistent pain arrives, it enables a person to shift from being, inverted commas, healthy or living with another long-term condition or two, to becoming far less active with the loss of their overall physical fitness with weak, stiff, tight muscles and joints. The combination of all of that leads to a whole series of issues around weight gain, sleep problems and fatigue because they're losing their strength, their stamina. But in addition, the emotional and cognitive consequences that actually impact on people as they become more fearful, more frustrated and angry about the way the pain is impacting on them, their lives and their health, and on other people. That therefore is compounded by the impact of depression and mood swings. And then, of course, there's all the social impact in terms of both relationships, ability to work and having time off work, and then inevitably the issues around money and, for some, the poverty cycle. Now, I have to say, fundamentally, in the last 15 years, what we know about pain, its neuroscience, has radically changed. And we are now potentially, for the first time, at a frontier in being able to make a difference. But what makes the difference is what we need to ensure is communicated to people who have pain, their families, their communities. How it really works today is in this particular slide. We are not working on the Descartes model of trying to find a cause and fix it. The days of that have long gone with chronic pain. What we're now entered is a world where the brain itself, in terms of its processing, is now giving more than adequate focus of attention, is actually drawing out other pain memories, is actually using the mood sensitivity and vulnerability to wind up the sensitization that's happening within the neural networks within the brain. All that and the sleep problems that emerge impact on how the brain is processing pain, and the nerve system that handles all of this becomes way oversensitive, and that people are often making repeated or catastrophic interpretations of what the pain means. Now, there's just in this last week a really interesting paper where you can actually get people together in a group and get them to understand the pain and their brain and enable them to work with it by getting fitter and stronger, but make much more accurate interpretations of what's actually happening with their pain experience in the moment. And that is leading to now in clear evidence of recovery. So we've got good news if we take a biopsychosocial contextual approach, making sure that we understand people's past and present life experiences, their memories, and all the other aspects of where the brain is in the master control box of what's going on. We can make changes. It's exciting stuff. So that new understanding of the neuroscience of pain is fed into the International Association for the Study of Pain revised definition that came out last year. And what's important that everybody has to know, which is what the issue is for people who present with pain, is they're saying, it's me, it's happening to me, it's a personal experience. All right. And this is how it is. And they're always wanting to share with you how it feels, the daggers, the lightning, the boring, which is fine. But that information actually for us who are going to work with them is actually not terribly helpful in some ways. What we really need to know is how we can work with their personal experience, past and present, their memories, their sleep issues, and all those other aspects on the cycle of pain that we've just looked at. And that's really where we've been working over the last 2 years in this area of biopsychosocial, and particularly in changing the impact of pain, what we call the self-care cycle. This offers people a real opportunity that if they engage in having more understanding of their brain, and how it handles pain, more accepting that actually for the present, the pain is here to stay, but we can influence it by enabling you to undertake clear, adapted or new skills, use tools and resources that can help you to become more active, set rewarding goals, plan and prioritize how you do your activities, and then address areas around sleep and moods, unhelpful, catastrophic, negative self-talk, and be ready for the setbacks that inevitably happen, but they're now less stressful, and you become much better at problem solving. And in the middle of all of this, there is now emerging stuff around the importance of healthy eating and particular types of approach to eating in terms of food content, particularly helpful. So this is a total person-centered type of approach in the self-care cycle. And what's quite clear is that clinicians have very little knowledge of the neuroscience and how to use that in conversations with people with pain, and have very little understanding of the role of self-care, the knowledge, skills, tools, and resources. And on this particular slide, you'll see that we've got a series of feet with numbers in them. And essentially what we've been working on is the emergence of a 10-footstep program approach for both clinicians and for people with pain to gain up-to-date knowledge, a clear understanding of the role of some key skills, and know where to find trusted tools and resources. And that's very much emerged within our work in the Live Well with Pain and the My Live Well with Pain websites that now host the 10 footsteps programs for both clinicians, social prescribers, and in the My Live Well with Pain website, the one for people with pain. So what are people with pain and their lived experience sharing with us? They're saying, support us, care about us, so that we can move ourselves from this enduring suffering to a more enjoyable, rewarding life. And really the bottom line message is just one of common humanity. A compassionate message really is, listen and walk with me and guide me from that unending quest to find the solution. And that's important because in doing that, you're enabling the person, once they feel understood, have got the right level of kind of empathy and support, that they will take control of their own experience. And so for many people with pain, helping them to see the new direction of a different journey becomes that of being a coach, a friend, an enabler, an empowerer. But they need to engage in it. So it's a hands-off, not hands-on approach. So what's emerged, as I've said already or mentioned briefly, is the My Live Well with Pain website for people with pain, which has a range of trusted resources. They're created in such a way that they're way more engaging. They're in video and format, animated at times, and then we've got very engaging, well-illustrated leaflets for people who will struggle with literacy issues. We've got some positive stories of people who've made it through, and we're in the process of adding support for the carers of people with long-term pain with a 10 footsteps program for them. And what does the 10 footsteps program look like that then was used subsequently in the GOT project? It looks at all those areas around the self-care cycle and brings into one place crucial bits of knowledge, crucial skills to begin to look at and try and work through yourself, or with support from clinicians, social prescribers. And it provides you with the trusted resources and tools. There really is an issue around clinician and social prescribing confidence in this area. They really are lacking in confidence, and all the effort has been focused both economically and socially in the person with pain direction, and really has ignored the need of the clinician end, which is why they will reach for a prescription pad and write yet another drug. It's not their fault. We just have not looked at the entire picture. So the last slide here really highlights something I think is fundamentally important. It's about enabling these people with PAIR to shift themselves from a suffering approach to themselves. They struggle through the darkness of the broken night's sleep to see anything else than suffering. And so what's important is that our approach and the way we talk and the way we link them in to what is there as supportive, helpful resources is important, because we're after, for a lot of these people with pain, the healing of long-term wounds that happen at intervals to all of us in our lives. But for them, at times, they actually take over much more than you would expect. So it's about recognizing that these people at times are quite broken in ways they may not even understand. They're quite wounded and hurt, often at times linked to actually the services that we provide within the healthcare system. After all, just to be dismissed with another prescription of opioids is not part of a healing, supportive direction of travel. But the neuroscience is highlighting, particularly for a compassion-focused therapy, that if we enable that person to become more compassionate to themselves because we're demonstrating compassion, in that way we're enabling them to soothe and increase their own endogenous opioids, because those endogenous opioids take a back seat as all the other neurochemicals take the front seat in pain. So that's the direction of travel that we're on. And now Paul is going to share a little bit more about how we took the 10 footsteps approach out into the primary care world and why. Paul, over to you.
Okay, thank you very much, Frances. Beautifully introduced, as ever. And you haven't really left me much to say, to be honest. I mean, Frances has really summarised exactly the programme that we've been working on. I mean, she's been working on this for 25 years. We've only sort of come in at the end to take the glory, I guess, in terms of developing this programme. So I'm going to tell you in the next few minutes, I'm going to flip through most of my slides because Frances has beautifully explained a lot of what I've got on some of my slides. So this is, she mentioned the GOT program. This is what GOT stands for. So this is our gabapentinoid and opioid tapering toolbox. This is a program that we've developed over the last few years to help the medical practitioners, particularly the GPs, to facilitate this self-management of chronic pain. And what I'm going to do is just briefly, because again, Frances has explained the elements of the GOT toolbox, but I'll just touch on a few things that weren't mentioned along the way. So we basically have developed this. Do you want to move the next slide, Frances? We've developed this program locally because we do have a significant issue locally in the Northeast and Cumbria. We have the highest prescription rates for opioids in the whole of the UK, and particularly very close to here in Durham. And in April, NICE, the National Institute for Health and Care Excellence, finally came round to the idea that we have a problem with the biomedical approach. And in fact, they've taken all the evidence on board and have now sent out an edict, in essence, to reduce or even stop the prescriptions of opioids and gabapentinoids in particular and other pain medications based on lack of efficacy and also on significant safety issues. We knew this for many years. Frances has been talking about this for the last 25 years. We've known this for many years, but finally NICE have actually realised this. However, the problem is NICE have not given us alternatives or given GPs alternatives to take people forward in terms of their pain self-management. That's where our programme comes in. Next slide, please, Frances. So basically the GOT program was developed, well, had been developed before this edict came out in April to address this issue, knowing that it was basically coming up. So the GOT program, we had a prototype locally in County Durham, in a practice in County Durham, a large practice in County Durham that had a very significant level of prescriptions of particularly opioids. In fact, it was the highest in County Durham at the time. So we started with the toughest job, if you like, and we were approached actually by the practice because they were desperate. They needed some help in actually managing their pain management program. So this is a perfect place where we set up the practice. Next slide, please, Francis. So you've already seen this slide. This is the footsteps, the 10 footsteps that Francis have mentioned. And this is what we have used in our training of the GPs and developing their skills in being able to increase their confidence, because they started very low, and at the same time increase patient confidence to manage their pain. And ultimately, safe prescribing is an ultimate aim as well of the program, because there will be some degree of biomedical requirement within pain management, but it's significantly reduced. And for example, antidepressant drugs, there is evidence base for some limited use of those drugs in pain medication. Anyway, moving on to the next slide. So it's all about confidence, building clinical confidence. That's why we set up this program. So it's really increasing knowledge, skills, and confidence. Generally, if you do your medical degree, you get about 5 minutes on pain, basically, which is true of quite a few other topics as well, but pain very limitedly covered in a clinician's life, certainly in the early days. So the knowledge is lacking, skills are lacking, and confidence is certainly lacking in primary care. So we set up a series of training programs, sort of health coaching, training programs in terms of education, in terms of giving the skill sets to the GPs to take back to their practice and develop with their individual patient groups. So moving from a biomedical to a biopsychosocial approach, as Francis talked about. Okay, next slide, please. So that obviously needs technical abilities, because to build this into a practice, it needs to be implemented in the practice. It needs to be built into the IT, into the very heart of the general practice system. So we help them also with this by developing a pain health check for the GP, so they can easily use it to follow the history of their individual patients through their life with pain. Okay, next slide, please. And this is sort of what it looks like if it just does so on the screen. So there's various elements there within the pain health check to help the GP, again, give them confidence, give them time. They haven't got very much time with their individual patients, so this is to help them to manage or help the patients in a team nature, to help them patients manage their pain. Next slide, please. I'm just going to show you some data. So I'm a scientist, I'm a pharmacologist, so I'm just going to show you some data. So these two graphs, these spider graphs, you don't need to necessarily see what's around the edges, but basically these are a series of questions for the GPs which indicate their levels of confidence. So the smaller the number, i.e. the smaller the spider graph there, the least confident the individual GP was. So this is an average data set here. So early on in the process, before we introduce the program and the training, this confidence is very low. That's a take-home message. As over time, and with the introduction of training, with introduction of resources, etc., you can see just by eye that the size of the spider graph has increased. In other words, the GPs appear to have got more and more confident. This is actually the mid-trial data set, and in fact, we've got the end of the trial data, which is even looking more impressive, with significant changes in GP confidence. Next slide, please, Francis. This is now some numbers in terms of the biomedical side. So this is some graphs which show you, and again, you don't need to necessarily understand exactly what's on the graph, but it's quite, if you look at the bars in each of these graphs, this is where we introduce the concept of GOT and introduce the program. And you can see very easily by eye, this is looking at high dose opioid prescriptions in this particular practice. This is our standard practice. You can see in all cases, the ones below that are the gabapentinoids, so gabapentin and pregabalin. You can see just by eye, you can see the massive or profound difference that the GOT program has made to this individual practice. In fact, we've gone from the top prescriber in County Durham now to below the national average in less than a year, despite COVID. And these two graphs, just to finish off, which are a bit clearer, this is again following over time. So we introduced GOT in late 2019, and then we introduced the training programs. On the second dotted line, you can see a profound drop in gabapentinoid use and prescription. And the shaded areas are actually the lockdowns, just to give you indications of what's happened during the lockdowns. The next slide, please. And similarly, which is even more dramatic, for the high dose opioids, we're talking very high dose opioids, 120 meg equivalent. We're talking very high dose opioids that can potentially cause massive health issues and even death. I don't want to be too dramatic, but these are very dangerous doses of opioids. You can see we've reduced the high dose opioids in this practice to, I think there's basically 3 individuals in the practice that are still left on high dose opioids. So a really dramatic effect of the GOT program. But it's only the beginning, and we need to carry on. So the basic take-home messages from the GOT program thus far is increased confidence for clinicians in terms of knowledge, skills, and use of the tools and resources. Remember, these are all free. These are all geared towards the NHS. This is all geared to free delivery of systems. So we've got a significant, profound reduction, certainly in high dose opioids and total gabapentinoid use. And we've got a systematic approach to pain management and medication built into a general practice. And obviously, the goal now is to roll this out locally and potentially internationally and nationally. And I'll stop there and I'll pass on to Chris Pennington, just to introduce Chris. She's our colleague in University of Newcastle. She's a clinical psychologist, and she's been working very hard on the sort of follow-up project to this GOT program in terms of community pain self-management. Chris.
Thanks very much, Paul. Can we move on to the next slide, please? And thanks very much for inviting me along. So I'm here to talk about the Footsteps Festival, which very much does link into the innovations that Paul and Francis have been talking about. And the Footsteps Festival is something that a number of people got together, including Francis and myself, and a whole range of other professional people, and an equal number of people with lived experience of pain. And we really wanted to make pain management resources and self-management resources available and accessible to people who might have difficulty accessing them. Now, from my experience, I used to work in a general pain clinic. I used to provide self-management support very frequently. And even in normal times, I was very aware that this was a really scarce resource, something that's just quite limited. It was very useful to people. It was very valuable to people, but not everybody could get access to it. And we really wanted to improve the access people had. And when the lockdown came over COVID, the first lockdown, even more so, there were people struggling having access to services. And we really wanted to provide a whole lot of self-management that we knew was effective and helpful in a more accessible format, and very much co-produced by everyone who might be interested in doing that. So if we can have the next slide, please. So we were lucky enough to get some funding from Francis to add to the Live Well with Pain site, to add a footsteps area. And the conceptualization was that this was just like a festival. It was like the equivalent of going in the summer to a festival, and there might be different events on different stages and in different tents, and people could really get together as a community, taste the different events, try different things out, and really expand their ability to self-manage their pain, because there are so many different facets of self-managing. And going back to some of the things that Francis said about people with lived experience, really valuing being connected, really valuing the compassion, the common purpose. But another thing that's really, really important, and this was unique probably, even from pain services, was the importance of fun and cultivating positive emotions, because pain can be so much about the negative and about trying to get away from the negative. But as well as that, a really important part of it is, well, if we cultivate the positive, actually we have a lot of evidence that that has very, very good effects, and actually can sometimes, in terms of the neurophysiology, be more important than actually getting rid of the negative. So if you see some of these events here, we've got a pet show, there was cookfulness, an absolutely wonderful series of sessions run by Opera North, which is all about singing, which has been very, very well received by people. We also, where we did have some more traditional sessions, such as understanding about pain. One of our collaborators, Cormac Ryan, came on and presented that very much in a very light-hearted way, linking it to a Dr. Seuss book, bringing humour into it, bringing fun into it. And you can see we have also the more traditional things that you'd expect to see on a pain management programme: mindfulness, thinking about pain, but very creative things as well. So we've really worked together to co-produce between professionals, but people living with pain, and very much led by people living with pain, a community with wonderful resources that people can connect with and tune in with. And we also have a regular weekly coffee and chat where people can actually just come along, and we have a craft and chat that runs sometimes where people can actually be in each other's company and enjoy that connectedness. Can we move to the next slide, please? So we set some guidelines for our groups, and one of the really important things that we decided early on is that there would always be a lived experience volunteer on our events, and often a pain management professional as well. And we've provided a variety of live and recorded content. So this personal interaction, we think that's really important. But as much as possible, we've recorded things so that there is increased accessibility for people who maybe can't attend at the time or can't manage to sit in front of their screen for that amount of time, so they can catch up later. And nice visuals that hopefully you can see some examples of on the slide. So our particular hallmark, as I've said, has been around enjoyable and meaningful activities to really get away from this typical response to persistent pain, which is trying anything and everything to fight the pain. And we know now that that doesn't work, and actually it can increase the threat of pain the more that we try to fight it. And our lived experience colleagues, very much from their experience, know that pain responds much better to enjoyment and fun. And so we've got such a variety, enjoyable and fun activities, including cookery, creative writing, zentangling, therapeutic knitting, the singing, the coffee and chat. I really couldn't cover all the different things that we've got on. And then here's the more standard courses that you might see. So there's a couple of us are trained mindfulness teachers. Dermot, the physio, who's one of the core members of the group, has offered 2 mindfulness-based stress reduction groups. I've been involved, along with Francis and a lot of lived experience people, with a 10 Footsteps course that we've run online as a self-management support session in a flexible way. And there's been the Step Into Singing that's come along, but just in a different format and a much more open format for people coming along. And what we've aimed to do in that, next slide please, is really move people between these cycles, which Francis introduced early on. So move people from the pain cycle into the self-care cycle by allowing them to access the kind of support and fun alongside the kind of information that they need to do that. This has been the aim of all of our activities. And by engaging with this, people can improve so many aspects of their life, the primary aim is to improve their life, but for many, this will have a positive impact on their pain as well. So just finally, looking at how people benefit, this is some feedback that we've collected from people who attended one of our courses, the 10 Footsteps course, about what they learned and what they found to be beneficial to them. And we can see this, that taking back their life and not giving in were really important aspects for them. But actually, understanding pain and the experts' guidance to do that, having tools that they can use, perspective from both experts through professional training and experts through living with and helping other people with the condition, the trust in the community and the self-care came out as absolutely key to people in actually being able to benefit and get to a better place of more confidently managing their lives and living a good life with pain, and perhaps for some with reduced pain. They came out as absolutely key. And I have to say, we're particularly proud that we've made this opportunity available to people through the lockdown period. And we've all done this on a voluntary basis. We've had an awful lot of goodwill. There's so many professional people, so many people with lived experience, really with no other motivation other than that we want to help people, we want to make things better for people. And it's really snowballed and it's become a really helpful, important thing. So if anybody is interested, just finally, we're always looking for volunteers. We're particularly looking to increase diversity. So anyone that would like to be involved or be interested in promoting what we do amongst your networks, please look at the festival pages. They're on the Live Well with Pain site. And we are also always looking for donations, none of which goes to pay any of us, but does go to cover our costs. So please have a look and please consider helping if this is something that is within your interest as well. Thank you very much.